Thank you, dear Chairman, ladies and gentlemen. It's a real privilege to be here this morning, and thank you for the organizers, Professor Yacoub, Adrian, and Ajit for organizing this and inviting me. It's really humbling to be here and talking to you about the Ross procedure under Professor Yacoub's invitation, since he really so generously taught me everything I know about aortic surgery and continues to inspire my daily practice till now. Now, my talk this morning is regarding the Ross procedure and a clinical perspective to it. So I'll give you some of my views as to where I think the Ross procedure stands in the surgical armamentarium nowadays. And to do that, I'll just introduce briefly the rationale behind the Ross procedure by talking about the aortic root. And then I'll talk about briefly about standard aortic valve replacement procedures, some of the most recent data regarding long-term outcomes. And finally, I'll talk about the Ross procedures and how that compares. So my first point is that the aortic root, as you well know, and as we've seen through the last couple of days, is a living structure. And I don't need to convince this particular audience about the fact that it is a living structure. This is one of many papers looking at aortic root physiology and dynamic physiology during the cardiac cycle, looking at a sheep model. And what, as you can see from the graph here, there are changes in the shape and form of the aortic root at all different levels, both in terms of torsion, in terms of the orientation of the aortic root itself, and some of these changes precede the changes in transvalvular pressure gradients, suggesting that the living structures in the aortic root really allow the root to allow that big bolus of blood to exit the heart during systole in such a short time without any obstruction. And all that is due to the fact that the aortic valve and the aortic root is a highly complex and a structure that is well preserved across species and across humans. And you all know that this is an aortic valve leaflet, a section through it with a monolayer of endothelial cells on both sides. We've talked and we've heard many speakers talk about the heterogeneity within these cells themselves, within the valve. And the structure within the aortic leaflet is a well-preserved structure within something that is hardly half a millimeter in thickness. We have a tri-layered structure with collagen on the aortic side, elastin on the ventricular side, and glycosaminoglycans in the middle to allow all these layers to move together. And within that is a mixed family of cells, which we call the interstitial cells, which are a mix of contractile cells, smooth muscle cells, and secretory cells with myofibroblasts and fibroblasts. We also know that there are neurofilaments and nerve cells within the aortic valves. Their function is still widely unknown, but their presence definitely does suggest a very complex function within the aortic valve. And previously in the lab with Kartik Balachandran, who was here in this meeting, we had looked at the mechanical properties of aortic valve leaflets in vitro, using a biaxial mechanical system. What we managed to show was not only the anisotropy in the aortic leaflets in the radial and the circumferential direction, as you well know, but also importantly changes in the stiffness of the aortic valve leaflets in response to endothelium-dependent stimuli such as serotonin or endothelin, and these were reversed whenever we inhibited the endothelium, whether mechanically or pharmacologically. And that is a real testament to the living nature of these aortic valves and their complex function, which we briefly understand for now, and we're continuing to learn as we have seen over the last couple of days. Now, that living structure from a physiological standpoint in living human beings really does translate into complex functions, and these translate in a human being in perfect laminar flow in a normal tricuspid aortic valve, in excellent hemodynamics in a healthy valve and root, in low thrombogenicity, in good resistance to infections, and all these items which we just mentioned will have a major impact on patient or subject survival, on the rate of valve-related complications, and on the quality of life of patients. So the rationale behind the Ross procedure is really the idea that a living aortic valve substitute because it may reproduce some of these functions which we talked about in the previous slide in terms of flow and thrombogenicity and resistance to infection, may translate into improved clinically relevant outcomes. Now, the Ross procedure really concerns mostly young adults, and young adults can be defined in many different ways, but young adults are essentially these types of individuals. These are two of my surgical colleagues in Montreal. On the left side, a 53-year-old Dr. Pellerin, who just finishing his Ironman after 11 hours and 20 minutes. And on the right side is Dr. Paget, who's as you can see, a 62-year-old accomplished water skier and who's just finished climbing the Himalayas. So young adults are individuals who, if we want to define what they really are, they have a high level of physical activity. Quality of life is a major element in the choice of prosthesis or surgery in these patients. And these patients have a prolonged life expectancy, and that means a prolonged exposure to potential valve-related complications, whether they may be degeneration and reoperation with tissue valves, or bleeding and thromboembolism in the case of mechanical prosthesis. So my second point this morning is the following, that standard aortic valve replacement in the young is associated with excess mortality. And if we look at some of these data, this is a study that's starting to date now, but still very relevant when talking about standard aortic valve replacement with prosthetic valves. This is a Swedish study looking at aortic valve replacements, whether mechanical or bioprosthetic valves, in the overall Swedish population, looking at observed versus expected survival of these patients in the long term. And what we do observe is after a period of about 7-8 years after surgery, we start observing an excess mortality in the patients who underwent aortic valve replacement versus the expected survival in the general population. If we look a little deeper into the detail of that paper, when they stratified the patients according to their age at the time of surgery, what was most striking is the observed versus expected ratio of death in these patients was the highest in the younger patients. And that might sound slightly counterintuitive. One would think that a young patient who has aortic valve disease that's now been replaced would have a normal survival in the long term. But in fact, the younger the patients are, the higher the difference or the excess mortality in these patients is in the long term. Sorry, this is a French, but essentially it just says what I just said now. Now, standard approaches, as you know, are mechanical prosthesis or tissue prosthesis, and these have several advantages. They're standardized operations, they're very easily reproducible, the operative times are short, and we have rather solid long-term data with these prostheses. Now, if you look at the long-term data with standard aortic valve replacement, the data is actually quite humbling, and these are some of the papers that are out there. One of them is a study that we recently published looking at isolated mechanical aortic valve replacement in young adults, which we defined as under 65 years of age. We looked at patients operated from 1997 to 2006, so a contemporary series of patients, and they were all consecutive patients. We excluded all concomitant procedures, coronary disease, reoperations, emergency cases, including dissections, and endocarditis patients. So any reason why these patients may have, or anything that may impact these patients' long-term prognosis. The mean age of the patients was 53 years at the time of surgery, and the mean follow-up was 9 years and was 95% complete. And what we did observe, when we compared the long-term survival to the Quebec age and gender matched population, was a significant difference at 10 years, which seems to continue to increase at 15 years. And overall survival at 10 years in these patients, again, isolated elective mechanical aortic valve replacements in patients who are 53 years old, was only 87% at 10 years. And if we combine survival free from reoperation, i.e. the chances of still being alive and not having required a reoperation in these patients, at 10 years, survival free from reoperation was only 82%. That is, at 10 years, 1 in 5 patients was either dead or reoperated. So the data is quite perhaps thought-provoking, but that is actual data from a tertiary center with patients having a very close anticoagulation follow-up. And in the details of that paper, as you will see, we don't have too many thromboembolic or bleeding complications, so these patients had a very adequate anticoagulation follow-up. And we performed a similar study looking at tissue aortic valve replacement, again in young adults, looking at their long-term survival. This is actually a study from the Cleveland Clinic looking at a similar outcome with over 3,000 patients undergoing tissue aortic valve replacement from 1991 to 2004. And the conclusion was that younger patients had worse than expected survival that was further diminished with insertion of a small prosthesis, which introduces an important element in these young patients who have a high level of physical activity, and that is the notion of effective orifice area and patient prosthesis mismatch. In fact, when we look at these patient survival in the long term, stratified per age groups of these patients, as expected, the patients under 65 years of age had a better long-term survival than the elderly patients. However, patients in the younger age category had a lower than expected survival compared to their matched population, as opposed to the two other patient populations. And if we look even further at the effect of patient prosthesis mismatch, that affected survival in these younger patients even further, as you can see here from this curve looking at 10-year survival. So in young patients, avoidance of patient prosthesis mismatch has a significant impact on survival, and that will be relevant when we talk about the Ross procedure in just a minute. And the final study I want to show you with regards to standard aortic valve replacement in the young it's another study that we recently published from our group looking at tissue aortic valve replacement in the aortic position in patients under 60 years of age. And again, looking at a similar exclusion criteria as the mechanical valve study. The mean age of the patients was 51 years and the mean follow-up was 10 years. And similar to what we observed in the mechanical prosthesis group, the survival of these patients compared to the age and gender matched general population was significantly lower both at 10 years and continued to widen as time went after the operation. Importantly, absolute survival at 10 years in these patients who were 50 years of age at the time of surgery was only 79%. And looking at the freedom from structural valve deterioration in these patients, again at about 15 years, you can see that almost 40% of these patients had significant structural valve deterioration and required reoperation. So my point to you this morning would be that standard aortic valve replacement in the young is far from a curative procedure, but rather a palliative procedure, and there's much more work that we need to do to address these shortcomings. Now, the Ross procedure may address some of these shortcomings to a certain extent, and we'll talk in a bit more detail about some of these results. As you know, the Ross procedure is an operation which consists of harvesting the pulmonary root and implanting it on the aortic side, either as a total root replacement or using a subcoronary technique or an inclusion cylinder technique. The operation was first described by Donald Ross back in the 60s, and since then has had many new iterations to the operation, which I'll describe in some of the following slides. The important thing about the Ross procedure is it's the only operation which guarantees long-term viability of the aortic valve and the aortic root. And that is really the premise behind that operation and the reason why we believe that some of these results, which I'll show you, are as published. Now, there are a lot of negative biases associated to the Ross procedure, and some of them may be well supported, some of them may be slightly biased, but the main criticisms are that it may transform a single valve disease into a double valve disease, that perhaps it would be associated with a high or a higher operative morbidity and mortality than standard aortic valve replacement, and that it's associated with a high rate of reoperations. And we'll look at some of these elements. Now, the potential advantages of the Ross procedure, as we said, it's a living valve which remains alive, and it really is the only operation for the aortic valve that allows this to happen. It has excellent hemodynamics with no patient prosthesis mismatch. It requires no anticoagulation and has excellent freedom from valve-related complications. And therefore, one would expect that because of all these elements, one would have better survival, hemodynamics, and so on and so forth, which is what we'll look at just now. So the point that I would want to underline is the fact that the Ross procedure really does translate into improved clinically relevant outcomes, and we'll take them one by one. First, looking at survival, and there's a plethora of studies right now in the literature in the last 10 years or so which have shown a survival benefit associated with the Ross procedure. The first of which was this paper by Professor Yacoub's group in combination with the Rotterdam group, looking at long-term outcomes following the Ross operation in young adults. The mean age of the patients in that patient population was 35 years of age. And when they compared them to the UK age and gender-matched population, what was observed was a survival which was almost identical in these two populations. And that was really the very first paper showing a restoration of survival in the long term after aortic valve replacement using any sort of approach. And since then, many groups have analyzed their long-term results following this operation. And I'll just show you briefly a few of these studies. This is another study from the Toronto group looking at 212 patients. The mean age was 42 years of age. And as you can see, in the long term, up to 15 years, the survival was exactly similar to that of the Ontario age and gender matched general population. In fact, the prolonged follow-up to that study was just published this year, showing continued matching between the survival in both these populations. This is Hans Siever's group in Lübeck, who published their 14 years experience with 500 cases using a subcoronary approach. And again, you can see that the patients undergoing the Ross operation had a survival which is exactly identical to that of the German age and gender matched population. This is the Rotterdam group, which, as I'll show you later, despite a rather high rate of reoperation in these patients, also showed survival which was exactly identical to the Dutch age and gender matched population. And a few years ago, I had the opportunity to analyze data from this prospective randomized trial, which was performed by Professor Yacoub, comparing patients or young adults undergoing either a Ross procedure versus a homograft aortic root replacement. 216 patients were randomized in that study. These were essentially all-comer patients. The mean age of the patients was 39 years in both groups. The reason I mentioned they are all-comers is if you look at the rate of endocarditis, 8% of patients in each group were operated on for active endocarditis, and almost half the patients in each group were reoperations, so patients had had previous operations. So far from a very highly selected patient populations as one sometimes hears about the Ross procedure. And looking at the long-term outcomes in these patients, the mean follow-up was 11 years. Up to 13 years, the survival of the patients undergoing the Ross procedure was exactly identical to that of the UK age and gender matched population, as opposed to patients undergoing aortic homograft replacement, where survival seemed to dip slightly compared to the patients undergoing the Ross operation. Now, one may argue that these are very selected studies, that there may be a bit of an element of cherry picking of these studies. So Hanneke Takkenberg performed a systematic review and meta-analysis of the literature looking at long-term outcomes following the Ross procedure, which we published a few years ago now in Circulation, looking at over 5,000 adults and children from 2000 to 2008. And her conclusion was that late mortality rates are low and resemble the adult series age-matched population mortality. Again, underlining the fact that the Ross procedure seems to restore patient survival in the long term to that of the age and gender matched general population. And in an accompanying editorial, it was mentioned, as we have been repeating, and Professor Yacoub has been telling us for many years, that this exceptionally high survival after aortic valve replacement may be due to patient selection, but it more likely is due to the low risk of valve-related deaths and cardiac-related deaths because of the pulmonary, autograft, hemodynamic, and biological features. So these are some of the data on survival following the Ross procedure. What other potential benefits are there to this operation? One of them may be hemodynamics, and which really is an important element in patient exercise capacity and functional capacity in the long term. Rio Tori, who will be presenting later this morning, had looked at patients undergoing different sorts of aortic root replacement procedures, whether it was a Ross procedure, a freestyle, so a bioprosthetic porcine root, or aortic homograft replacement, 10 or more years after the operation, looking at the dynamics of flow through the aortic root using cine MRI, and we compared those to normal individuals. And what we observed was that the pattern of flow and the velocity of flow and the shape of the flow in the aortic root was most closely resembling that of a normal individual in the autograft or the Ross group compared to the other two groups undergoing aortic root replacement. Now, in clinical terms or in echocardiographic terms, this translates into very low transvalvular gradients in these patients, which invariably are in the single digits in terms of mean gradients. And importantly, these gradients do not progress over time, as opposed to what we observe with the aortic homograft. This is from the randomized trial, and as similar to what we observe with tissue prosthesis, where the gradients also have a tendency to increase as the valve degenerates with time. And in terms of the impact of these low gradients on patient functional capacity, this is a study from the Quebec group that was published by Philippe Pibarot a number of years ago, looking at the valve hemodynamics in patients with the Ross, following the Ross procedure versus healthy controls. And what they did show was that the peak gradients and the mean gradients in patients with the Ross operation versus control were exactly similar when the patients were exercised at different types of exercise capacities. And we don't have this sort of data for prosthetic valves, whether tissue or mechanical valves, but one can easily imagine that these gradients do increase with exercise as the cardiac output increases in these valves, since these valve areas are fixed and do not increase with exercise, as opposed to the Ross or the pulmonary autograft, where the root really adapts to the physiological demand of the patient. Another important element in determining patient long-term outcomes is the rate of valve-related complications, and that is the rate of infection, whether it's endocarditis, the rate of thromboembolism, or the rate of bleeding if patients receive anticoagulation. And I will not belabor that point because it's rather obvious, although we'll hear later about the Dutch-German Ross registry and the long-term risk of complications and endocarditis. But essentially from the randomized trial, and this was a mean follow-up of 11 years, the rate of valve-related combination, when we combined all of those, was very low, with a freedom of valve-related complications of 96% at 13 years. And the majority of studies looking at these patients show low rates of valve-related complication, which does not mean an absence of valve-related complications. There is a risk of endocarditis both on the right and on the left side, but they are certainly lower than that of prosthetic valve replacements. So if everything is so rosy, what is the potential Achilles heel of the Ross procedure? Perhaps two elements. One is, or at least two elements that are regularly brought up in the literature. The first being the rate of reoperation, which can be sometimes alarmingly high. And two, the question of reproducibility of this operation, which is inarguably more complex than a standard aortic valve replacement. And in fact, some studies have shown some particularly high rates of reoperations. This is one of those from the Rotterdam group, showing a high and continuing to increase rate of reoperation at 10 years, and continued so. Now, if we look at that same group, when they looked at these patients who underwent or required reoperation, mainly because of autograft pulmonary autograft dilatation in the systemic position, what they did show was that most of the diameter increase was already reached at hospital discharge. So most of that increase in diameter was reached very early on and continued to increase, which brings us to an important point when discussing the Ross procedure, and that is that technique really does matter in determining long-term outcomes following this operation. And some of the technical key points which have been continually progressing and developing over the years, which Professor Yacoub has really taught us repeatedly, I will show you briefly in some of these slides. The first and very important point is to trim the infundibular muscle under the pulmonary valve leaflets when after harvesting the pulmonary autograft. This muscle here becomes devascularized after we harvest the pulmonary autograft and therefore provides no structural support. If one leaves a long sleeve of muscle here and implants that valve in a supraannular position on the aortic side, it will inevitably be exposed or prone to dilatation in the short and long term. It is important to scallop the autograft to try to follow the crown shape of the aortic annulus to best reproduce the functional dynamics of the root. Importantly, the pulmonary root has to be positioned in an intraannular or subannular position on the aortic side, and that can be done through very meticulous stitching of these of the stitches both on the aortic side and the pulmonary side. On the aortic side, the stitches have to be put in a subannular position or have to come out lower than the annulus, but importantly, on the pulmonary side, as you can see here, a section of a pulmonary root, you can very well appreciate the fact that the infundibular muscle is really what sits around the pulmonary leaflets, and there is no actual fibrous structure that one can call an annulus on the pulmonary side as one does on the aortic side. So these stitches have to be passed in a tangential fashion on the pulmonary side, exiting 1 or 2 millimeters above the level of the leaflet here, so that the root really sits in an intraannular position and is supported by the native aortic root. Perhaps I'll just skip some of these elements here. This is a video just showing the stitches, or illustrating that the passing of these stitches really at the insertion of the leaflet and exiting a few millimeters above the leaflet in order to position it in an intraannular position. The other critical point on the distal suture line is to keep a very short sleeve of pulmonary artery above the sinus-tubular junction, only enough to be able to suture, to perform the distal suture line, to avoid exposing it to dilatation when it's positioned in the systemic, under systemic conditions. Again, I'll skip some of these elements. The pulmonary homograft, we have learned from Professor Yacoub to systematically oversize the homografts, including in children and very young children even. The other important element in the postoperative course of these patients is to control their blood pressure as closely as possible from the minute the patients reach the ICU until the first 6 to 12 months, which is the period of time we think is required for the pulmonary autograft to adapt to its new environment. We know it does adapt. There's a layer of collagen that deposits on the adventitial side and a bit of thickening of the leaflets, particularly on the ventricularis side, which allows it to adopt a more systemic or aortic configuration in biomechanics. So I mentioned earlier that technique perhaps does matter, and when we look back at that initial paper published by Professor Yacoub and the Rotterdam group, if we distinguish both these cohorts of patients in terms of reoperation rates, we can appreciate the fact that the patients in this cohort had a much lower rate of reoperation in the long term than the other cohort, perhaps again underlining the importance of technical details at the time of operation on long-term outcomes or stability of the autograft. And when performing some of these elements, the rate of reoperation can be maintained rather low. This is the Toronto paper showing an 85% freedom from any reoperation, whether on the left or the right side at 15 years. So about a 1% patient year rate of reoperation. And from the randomized trial, again, the rate of reoperation both on the right and the left side was only 6% at 13 years. Perhaps in the interest of time, I may just briefly skim through the next slides. The question being whether it's a safe and reproducible operation. These are some of our data from Montreal. We started our program 3 years ago, and we've so far performed 120 patients, which were, it's a non-selected patient population. 16% of those were redo operations, 65% had concomitant procedures, mostly ascending aortic replacement. 5% had active endocarditis, and the median Euro score was 3.3% with an operative mortality of 1.7%. These are the characteristics of the patients. I will, again, briefly skip through those. But just to show you the hemodynamic differences in these patients, these are the index effective orifice areas before, immediately after, and at 1 year after the operation, with the line here being the cutoff for patient prosthesis mismatch. I mentioned earlier the importance of patient prosthesis mismatch on the long-term outcomes or the prognosis of these patients in the long term, and you can well appreciate the difference or the distance there is between patient prosthesis mismatch and the indexed effective orifice areas in these patients. Similarly, we, with a very rigid and close control of blood pressure and all the technical elements which I mentioned earlier, we closely followed these patients with echoes at specified timelines after the operation. And you can see that importantly, the sinus of Valsalva diameters do not seem to change much from the point of discharge up to 1 year after the operation, suggesting good stability. And as I mentioned, this may be a little early to determine whether this will be stable in the long term, but based on the Rotterdam group's observations of early dilatation in these patients and the fact that we believe dilatation may beget dilatation, having early stability, I think, is an important element for the long-term outcome. So what was a rationale behind an operation and a principle perhaps may be translating into reality, and the living aortic valve substitute may actually translate into improved clinical outcomes as we see in these patients. And therefore the role of the Ross procedure at this point in time would be in any patient with aortic valve disease that is non-repairable, who has a life expectancy of 15 years or more, is a potential candidate for the Ross operation. We're obviously not stating that it should be performed in all patients, but certainly should be considered in all these patients because of the data that was mentioned previously. Skip through some of these. So to conclude, I think that 3 important points to remember. The first is that in young adults, the choice of prosthesis has a direct impact on long-term prognosis of the patients. And that is truer as the patients are younger and less so as the patients get older. The other point that seems to be well obvious from the literature is the fact that standard aortic valve replacement using prosthetic valves or stented prosthesis is associated with excess long-term mortality versus the general population. And finally, the Ross procedure, i.e. a living aortic valve en route, does translate into improved long-term survival and quality of life, as shown in some of these data that I've showed you just now. So with that, I will conclude, and thank you for the invitation. I'll be happy to take questions.